Welcome to Chapter 35, Environmental Emergencies. So let's look at exposure to. This can happen in any setting, really, wilderness or rural, suburban, urban. And exposure may not be the only danger. It can involve pre-existing or cause additional medical problems and injuries. If you are subject to a cold or heat emergency at one point, then your chances of getting a more severe case down the road are increased. So how does the body lose heat? So we lose it through conduction, convection, radiation, evaporation, and respiration. Generalized hypothermia. So exposure to the cold reduces body heat. The body is unable to maintain proper core temp. This may lead to death. And some predisposing factors include shock, injuries, infection, or immobility. Diabetes and hypoglycemia also up the risk, as well as drug and alcohol abuse. Obvious and subtle exposure can happen. So it may be subtle, it may be obvious, it may not occur right away. So with alcohol and ingestion, underlying illnesses, overdoses and poisonings, major trauma, outdoor resuscitation, and decreased ambient temperature. Some of these can be subtle. Some of them can be obvious exposures. In older adults, cold temperature effects are immediate. During the winter months, many of these older patients are on small fixed incomes and live in unheated rooms that are kept cool. The environment then slows down the body systems, and they lack the activity that will lead to hypothermia. Kids, remember that they have this large surface area compared to their body. They don't have a lot of fat, so they are especially prone to hypothermia. And they're also unable to shiver because of their muscle mass. So assessment, so shivering is an early stage of hypothermia. Numbness or reduced or loss of sense of touch. They may have a stiff or rigid posture, drowsiness, rapid breathing and pulse, or it may be slow and absent in prolonged cases. They're going to have a loss of motor function. They're going to have some joint and muscle stiffness or muscle rigidity. They're going to have decreased level of consciousness or unconsciousness, cool abdominal skin temp, and red skin, pale or cyanotic skin in prolonged cases. So how do we get these patients rewarmed? So there's passive and active. Passive rewarming involves covering the patient and removing any kind of wet clothing. Active rewarming is we're going to apply some type of external heat source. Typically, we're going to do the passive type of rewarming because we don't want to rewarm them too fastly because it can cause damage. So we're going to remove any kind of wet clothing, actively rewarm the patient during transport, Provide care for shock. If the patient is warm, or I'm sorry, give the patient warm liquids if they're alert. And transport the patient unless it's a mild case. So this is for a patient who is alert and responding appropriately. We're going to do this active rewarming. For extreme hypothermia, the patient who's unconscious with no discernible vital signs, their heart rate can be slow to 10 beats per minute. They may be very cold to the touch. If there is no pulse, we're going to start CPR with an AED. And if there is a pulse present, we're just going to care for that patient who is unresponsive or not responding appropriately, as you would any other patient. And you're not warm and dead until, or you're not dead until you're warm and dead. We need to warm the patient's body back up to at least, I believe it's 86 degrees before we can call them and stop resuscitation efforts. Unresponsive and responding inappropriately. So we're going to do all the things for an unresponsive patient. We're going to ensure the airway, high flow O2 if needed, and if possible, we're going to pass it through a warm water humidifier. Wrap the patient in blankets and then transport immediately. Localized cold and injuries and frostbite. So this most commonly affects the ears, nose, face, hands, fingers, feet, and toes. The blood flow is limited by constriction of the blood vessels. The tissues then freeze and may form ice crystals. So there's a couple different layers of localized injury. So we can have frost nip. So we're just going to remove them from the cold and cover. It can be frostbite, and that's a late or deep injury. So we're going to give them oxygen and cover the frostbitten part and handle gently. So just like in burns, these can be developed over time. Or happen immediately. Because of that, they'll have the same kind of look to them as burns. So up there at the top, you're going to have that frost nip. Down there at the bottom, you're going to have frostbite. Again, frostbite compared to burns would be your 3rd degree burn or full thickness burn. So active rewarming of frozen parts is seldom recommended. We can have a chance of permanent injury. We're going to use warm water and a container in which you can rinse the entire site of the injury without touching the sides of the bottom. Again, not really recommended. We're going to heat the water between 100 to 105 degrees. Fill the container with the heated water. Remove any kind of clothing, jewelry, bands, or straps. Fully immerse the injured part and do not allow the area to touch the sides or bottom of the container. Continuously stir the water. If you complete rewarming, gently dry the affected area and apply dry sterile dressing. Keep the patient at rest. Make certain that the patient is as warm as possible. And continue to monitor the patient. Do not allow that limb to refreeze. So after it's frozen and unfrozen, we don't want it to refreeze. Transport as soon as possible. Heat exposures. So the effects of heat on the body. So heat that is not needed for temperature maintenance and not lost creates hyperthermia. Left unchecked, it will lead to death. And then we have these stages of heat on the body. So you can have heat cramps, which is your basic first stage of heat exposure. And with heat cramps, you're just going to have some cramping. Your patient's going to be warm. They're going to start to kind of feel it. Heat exhaustion, we're still going to have the cramping. They're still going to be pretty okay for the most part. They're going to need some intervention pretty soon. And then in a heat stroke, this is where the difference is that they are going to have this hot, dry, or even possibly moist skin. But more often than not, it's going to be hot and dry. And the main difference is that these patients are going to have stroke-like symptoms, and they're going to stop sweating altogether. So patients with moist, pale, and normal or cool skin is known as heat exhaustion. So as that sweating continues, the body loses salts, bringing on these painful muscle cramps. Healthy individuals may experience a form of shock brought about by fluid and salt loss, and it often occurs before a patient has been acclimatized to the summer heat. So they're going to have some muscular cramps, weakness or exhaustion, rapid shallow breathing, weak pulse, heavy perspiration, loss of consciousness is possible but usually brief. We're going to remove them from the hot environment, high flow O2 if needed, loosen or remove any kind of clothing, put the patient in a supine position, give them small sips of water, because if we give them big sips of water, they could vomit, and we don't want them to vomit. Allow a moist towel over the cramped muscles and transport. Heat stroke is a true emergency. The temperature regulating mechanisms all fail, and the body cannot rid itself of any kind of excessive heat. Patients who stop sweating cannot lose heat through evaporation. So they're going to have some loss of consciousness, altered mental status, rapid shallow breathing, full rapid pulse, generalized weakness. They may have little or no perspiration. They're going to have some dilated pupils, and they also have the potential for seizures, and they're not going to have the muscle cramps either. So we're going to remove them from the hot environment, apply cool packs to the neck, groin, and armpits, remove any kind of clothing. For kids, we're going to start using a tepid water, and then move to a cooler water, administer high flow O2, and then transport immediately. If you go to if your kids are on a football team, or you're near a football team during the summer months, they will typically have a tub out there that can be easily filled with ice water. And if that patient does go into heat exhaustion or heat stroke, they're immediately going to put that patient in that tub with water, and what's going to happen is that patient is then going to be staying there until their core body temp comes down below, I think it's 104. So dangers of extreme body temperature. So as the body temperature decreases, the muscles shiver, the heart is prone to dysrhythmias, and central nervous systems become sluggish. As it increases, sweating leads to evaporation and cool skin, and if that excess heat builds up, then the skin becomes hot. So water-related accidents, we have a lot here at the lake because we are at the lake. So we can have boating, water skiing, windsurfing, jet skiing, diving, and scuba diving. So assessment, look for an airway obstruction, cardiac arrest, signs of a heart attack, any kind of injury to the head, neck, internal injuries, generalized cooling or hypothermia, substance abuse, and drowning. Um, so, according to the World Health Organization, drowning is the process of experiencing respiratory impairment from submersion or immersion in liquid. Outcomes include death, morbidity, and no morbidity. Um, these patients, if they drown, they drown. Okay, they're clinically dead. Um, Now you can have a near drowning, where the patient sucks in a lot of water, maybe didn't breathe for a little bit, and um, maybe required some type of short resuscitation. But a drowning is clinical death. Okay, it often begins as the person struggles to keep afloat. When they start to submerge, they try to take one more deep breath, and then that water enters the airway, followed by coughing and swallowing, and involuntarily swallowing more water. Then the larynx has this reflex spasm that gets triggered, sealing the airway. Unconsciousness results from hypoxia, and some who die from drowning die from lack of air. Most attempt at final breath or are unconscious, and water enters into the lungs. So rescue breathing in or out of water. Do not delay transport. Begin rescue breathing without delay. If you reach a non-breathing patient in the water, support the patient in a supine position and provide ventilations. You may encounter airway resistance, and will probably have to ventilate more forcefully than other patients. Spinal injuries. So assume the unconscious patient or patient with head injury has a neck or spinal injury. Resuscitation should be started before you immobilize the neck and spine. You may not be able to complete assessment for spinal injuries while the patient is in water. Take care to avoid any kind of aggravating spinal injuries. Do not delay basic life support, and when possible, keep the patient's neck supported and in a straight line with the body's midline. Information supplied to the dispatcher or hospital from the scene and during transport is critical. Diving accidents. Remember, with a diving accident, we're going to have some type of compression injury, where the vertebral disc gets compressed. Most of these involve the head and neck. They also do typically involve the spine, the hands, the feet, and the ribs. Emergency care is the same for any accident patient out of water. You're just going to get them out of the water first. Scuba diving accidents. So, the patient can have an arterial gas embolism where the diver is holding their breath, and this may be due to inadequate training, equipment failure, or underwater emergency, or trying to conserve air. Decompression sickness. So this is when the diver surfaces too quickly from a deep, prolonged dive, and it takes 1 to 48 hours to appear. Typically, this patient is going to require some type of hyperbaric chamber. So your patient goes in at sea level, and then they go down, depending on how far they are, how far they started under sea level. Depends on how they are treated at the hyperbaric chamber. Signs and symptoms included an aerial embolus, altered mental status, rapid loss of consciousness, and blurred vision with seizures. Occasionally, really what's happening is your body is going into what's called nitrogen narcosis, and there's too much nitrogen in your body. So all these nitrogen bubbles start to surface. You can have some paralysis or paresthesia, stroke, numbness, tingling, generalized or specific weakness, frothy blood in the mouth and nose, incontinence, chest pain, stroke-like symptoms. They may have myocardial infarction, respiratory arrest, and cardiac arrest. For decompression sickness, they're going to have altered mental status and related symptoms. Fatigue, pain in the muscles and joints, called the bends. They're going to have some itchy blotches or mottling of the skin. They may have some numbness or paralysis, choking, coughing, dyspnea, substernal pleuritic chest pain, coughing, and peripheral edema and swelling. Okay. Maintain an open airway, administer oxygen, keep the patient warm, position the patient either supine or on either side. Continue to monitor the patient. You may have to reposition them to ensure an open airway, and promptly transport the patient. Again, these patients are probably, if your patient is experiencing decompression sickness, this patient is probably going to have to go to a facility with a hyperbaric chamber with the capabilities to be an emergent hyperbaric chamber. So your patient is going to require that they be taken back down to the depth that they were at, and then the oxygen tank, which is the big huge thing that you kind of lay in, pushes oxygen into your body to try and get rid of the nitrogen. Water rescues, so reach, throw and tow, row and go. These are your options for water rescue. We do not get into water rescues. It's more of a generalized overview of, here you go, this is what you can do to try and help your patient. So you're just not standing there watching them drown. Ice rescues, so the number one rule is to protect yourself. Ways to reach the patient: you can throw a flotation device, toss a rope, push out a flat-bottomed aluminum boat, or lay a ladder flat on the ice. We're going to treat the patient for hypothermia. Remember that the patient may not be able to do much to help the rescue process. Always transport, never work alone, and never walk out on the ice. High altitude emergencies. So there's a couple different ones that you can have, but for the sake of this, we're going to kind of keep it simple. So high altitude illness. So this is differences at higher altitudes. There's less air to breathe and there's decreased air pressure. Normal, healthy people who have adjusted to high altitudes have a lower oxygen saturation because there's less oxygen to breathe. And then we can have acute mountain sickness. Okay, this is a less serious case of a person experiencing problems adjusting to thinner air. In mild cases, all that may be needed to overcome the acute mountain sickness is rest and rehydration at altitude. And then in the more severe cases, supplemental oxygen and immediate descent should lead to improvement. These again, if you go down, the pressure on the body because of the atmosphere increases. If you go up, the pressure on the body because of the atmosphere lessens. So it's the same thing, it's the same treatment. So some of these patients are going to get a hyperbaric chamber. For acute mountain sickness, they actually have inflatable chambers that get inflated, like at summits and various things like that. So HACE is a high altitude cerebral edema, and this is the worst form of acute mountain sickness. And it is just as the name suggests, it is edema in the brain, okay, because of that high altitude. So you're going to have a headache that worsens over time, loss of balance and coordination, fever, severe fatigue, seizure, altered mental status, and loss of consciousness. In our care for this patient, we are going to arrange for immediate transport or descent, and all other treatments are secondary to this. And we're going to provide supportive treatment and high flow too. HAPE, so this is a high altitude pulmonary edema. Again, just as the name suggests, there's fluid in the lungs because of that high altitude. Signs and symptoms include shortness of breath, dry cough, that progresses to coughing up blood, tachypnea, tachycardia. They may have a mild fever, oxygen O2 set lower than other asymptomatic people in the same environment, and they may also have respiratory failure and arrest. We're going to arrange for immediate transport, high flow O2, minimize physical activity, and provide supportive treatment. Bites and stings. So all spiders are venomous. Whether or not they can bite you and cause any damage is the issue. Insect stings and bites are rarely dangerous. Anaphylactic shock is a major concern, and then we're going to remove the stinger quickly. Signs and symptoms include altered mental status. They may have a noticeable sting or bite on the skin, puncture marks, blotchy skin, localized pain or itching. They may also have some numbness in the limb or body part. They may have some burning sensation at the site, redness, swelling or blistering at the site, weakness or collapse, difficulty breathing and abnormal pulse rate, and then headache and dizziness as well. They might have some chills, fever, nausea, vomiting, muscle cramps, chest lightening, joint pain, excessive saliva formation, and profuse sweating, and then obviously anaphylaxis. Okay, so we're going to treat for shock, call for med control, and remove the stinger or venom sac if you can. Remove any kind of jewelry that's from the affected limb. Place constricting bands above and below the sting or bite site if on an extremity, and never over a joint if local protocols permit. And then keep the limb immobilized. Snake bites. So these require special care, but you are usually not life-threatening. Death is not sudden unless anaphylactic shock develops. We're going to stay calm, keep the patient calm and at rest, because if we don't, what's going to happen? All that venom is going to go because their heart is beating faster. A pressure immobilization bandage may be the most effective technique to slow the venom spread. Not a tourniquet, but a pressure immobilization bandage. So they might have a noticeable bite on the skin, which may appear as nothing more than a discoloration. They may have some pain and swelling in the area, and a rapid pulse and labored breathing. They may also have some progressive general weakness, vision problems, nausea, vomiting, seizures, drowsiness, or unconsciousness as well. Call for immediate med control, treat for shock, observe body heat, or conserve body heat, keep the patient calm, locate any kind of fang marks, remove any jewelry on extremity, and keep any bitten extremity immobilized and transport the patient. In this, there is also an anti-venom. There's a synthetic anti-venom as well. The problem is that costs $10,000, or I'm sorry, $30,000 a dose, and it requires 3 doses. So you really should know what kind of snake bit the patient, so that way you can let the hospital know and treat them. Marine life, we don't have a whole lot of marine life around here, but it can occur in a variety of ways. Jellyfish, shark bites, blunt force trauma from larger fish attacking or hitting people. It can be from a sting or puncture. I mean, it's just a variety of ways. Freshwater activities activates toxins on the skin, increasing pain. So use salt water to rinse the affected area. Okay. So if you have any questions, let me know, and I will answer those to the best of my ability.